Hello, good morning, dear friends. Today we are going to discuss the status epilepticus. This is one of the most common medical emergencies we are coming across during every work postings. So, what is a status epilepticus? Status epilepticus has been traditionally defined as more than 30 minutes of continuous seizures or more than two seizures without regaining of her consciousness in 30 minutes. But what has been happened is, if we consider for 30 minutes to wait and to treat as status epilepticus, we have lost many of the neurons. So gradually the definition has came, and nowadays the operational definition of the status epilepticus is any seizures which is lasting more than 5 minutes and has to be treated as status epilepticus, or any two seizures, discrete seizures without regaining open consciousness should be regarded as a status epilepticus. We usually focused more on a part of a management, but look at some of the features or epidemiologically usually used, so it is more common in children and old people rather than the young people. So it has a U-shaped curve of distributions epidemiologically. Etiologically, most of the patients who present to us with the status epilepticus are usually acute symptomatic. What are the acute symptomatic seizures? Acute symptomatic seizures are any conditions that's recent medical or structural conditions. Say for example, patient is having an acute hyponatremia. That's acute recent conditions, medical conditions leading to seizures. They are more likely to have a status epilepticus than those patients who is having an open epilepsy. A patient who is having an acute structural lesions, like having an acute stroke, they are more likely to have a status epilepticus if they at all get the seizures. Other group of patients who are the known case of an epilepsy on and drug therapy, but as you know, there are many drugs which cause drug to drug interactions with anti-epileptic that can cause a decrease in a drug level, and patient may precipitate with the status epilepticus. As with the patient withdraw the drugs by itself, who is on an anti-epileptic therapy for a long period of time, can come to you with status epilepticus. So these are the class of the patients who comes to you with a status epilepticus. Classify, they are usually, what we are talking about is generalized seizures, that is generalized our status epilepticus. We have a non-convulsive status epilepticus also, where we don't get the convulsive status, like absence convulsive status epilepticus. Clinical features, as we know, the epilepsy is lasting, seizures lasting more than 5 minutes, they have been traditionally defined as status epilepticus. Usually that diagnosis is clinical. We need to do the EEG, and EEG monitoring is must in a patient where after few minutes patient may have non-seizures which is not shown on our clinical examinations because of exhaustions, but ultimately on an EEG if we look at, the patient may have a continued activity inside the brain, and that may lead to brain injury. So continuous EEG monitoring ideally should be to the all patients with the status epilepticus. Now, how to manage this patient? So this is a management. Once the patient comes to you, you need to have an initial assessment, neurological examinations, which is very fast, and respiratory circulation examinations in the form the patient may need ventilatory support if the patient has been aspirated, and the patient may need ventilatory supports if the patient's oxygen saturation is very low. Blood investigation, specifically we can do the finger glucose test, especially patient who is in diabetic, where the low blood glucose level hypoglycemia has precipitated the seizures. We need to do the electrolyte, like hyponatremia can cause seizures, calcium, glucose, LFT, hepatic encephalopathy, and anti-epileptic drug level. Patient if on the anti-epileptic therapy, that needs to be done, because low level of anti-epileptic drugs will be the cause in these patients. So if we have drawn the blood for these ones, acutely once the patient becomes, we give the lorazepam. Lorazepam is the drug of choice because it has faster actions and somewhat and longer duration of actions. We avoid the diazepam as it has erratic absorptions and the distributions is not good pharmacologically as that of a lorazepam. We give in a dose of 0.1 milligram per kilograms or 4 milligram. We wait for 3 to 5 minutes, and if seizure is continuing, we are giving against the lorazepam. If IVSS is not available, we can give the midazolam IM. See, but these are the drugs which just disrupt the seizure. Now we have to add on another drugs. These are the drugs which prevents the further episodes of seizures. So two types of drugs are different benzodiazepine drugs. They practically halt the that episodes of a seizures, while these drugs they prevent the new onset of another seizures in that patient. So we have to give a fosphenytoins. Usually dose is 20 milligram per kilograms. Usually valproate is 30 milligrams and levetiracetam is 60 milligram. But as per in Harrison's, all are you can say 20 to 30 milligram per kilogram per body weight. So you remember 20 milligram per kilogram in an all fosphenytoins, valproate and levetiracetam is enough for you. But as such, the levetiracetam dose is usually higher. If we give all these drugs, usually patient should have the stabilizations as far as the metabolic derangement or something others which is the culprit cause if we remove that one. If still patient is having any convulsions, the patient needs to give either midazolam, propofol or pentobarbital, because these patients will have persistent seizures and they are sedated and put on a mechanical ventilator. Now they are to be considered to be having a somewhat of a refractory type of status epilepticus. These patients maintains on a ventilatory supports with midazolam or propofol or pentobarbital, usually maintained for 24 hours, and gradually we taper it off. So once the effect of this anti-epileptic drugs has came and patient is having no seizures on EEG, there no signs of the seizure activity, we gradually tapers off after 24 hours and patient continues on the anti-epileptic drugs. This is how usually we manage the patients with